Thank you so much for having me. I'm pleased to come and talk with you about INR testing. I'm glad that Jennifer Foster's talk came first because I think it's a little bit hard to talk about INRs if you haven't already been set up with it is the test that we use to monitor warfarin. So I started managing warfarin for patients in 1994, so I've been at it for a minute. In my previous job, I was with a very large anticoagulation clinic that actually they had a lab in the next room, and I was the supervisor of the INR machine that ran the tests. So I learned a lot from that experience. I'm very happy to be in a clinic now that is doing fingerstick INRs. It's a lot simpler. But I just kind of wanted to unpack the test itself, how we use it, what it's for, and then field any questions. There is, I think, some crossover, especially with my later slides in this presentation that Dr. Foster has already covered, so some of this will be review. Yay. So we're going to describe the INR test, how and why it's used, what is the range, what's normal, what is abnormal, and then risks associated with either high or low INR test. There's a slide that's missing. The INR does have uses beyond just warfarin monitoring. That's what we use, or that's what we think of it as being the primary use of it. But it was originally designed just to monitor clotting status. It can also monitor nutritional status. So, for example, people who aren't consuming any vitamin K or are very, very malnourished may have an INR that is elevated at baseline. They're not taking any anticoagulant drugs, but their INR is elevated. Newborn infants are given a dose of vitamin K because they're born without any vitamin K stores. Most of the vitamin K that we have in our body is from nutritional sources. About 90% of our vitamin K is from nutrition. About 10% of it is actually produced by bacteria in your gut. And of course, infants will be born with, they're not eating their greens for sure, and they also, their gut flora hasn't been developed yet. So infants are given a dose of vitamin K to reduce the risk of hemorrhage within the first week of life. The INR test is also used as a measure of liver function. So if a person has really advanced cirrhosis of the liver, their INR may be elevated. There's something called a child Pew score, which is a scoring system for determining how bad somebody's liver function is, and an INR elevation is part of that calculation. So the quick prothrombin test was developed in 1935. They call it quick not because it's fast, like a quick test to do. It was Dr. Quick who invented it. Although the test itself, even in a laboratory, can be done in about 10 minutes, so it's really a pretty quick test to do if you've got personnel that is moving the test tube from place to place on time. That seems to be the rate limiting step for it. It was developed as a test for measuring prothrombin, and if you remember, I did not put the clotting cascade, so I'm glad that Dr. Foster did. I find the clotting cascade to be very, very painful, brings back PTSD memories of pharmacy school, having to learn it. But if you recall, at the very bottom of the clotting cascade, there was where factor 2 was. And Dr. Quick identified this laboratory test that could be done that would measure the effectiveness of prothrombin, or factor 2, which is a vitamin K-dependent clotting factor. It became the standard for monitoring warfarin because of its ability to detect changes in vitamin K-dependent clotting factors. What I think is really interesting is that the test that we use to monitor warfarin was invented in 1935, about 20 years before warfarin was identified. So the test that we use predates the drug. It was apparent fairly early on in warfarin management. So warfarin was FDA approved in 1954. And then they used the prothrombin time as the method of measuring the effectiveness. And what I had learned in pharmacy school was a prothrombin time ratio. In other words, you would take your patient's prothrombin time, and then a therapeutic level was like 1.3 to 1.5 times the normal. The problem was that people identified that from one laboratory to another laboratory that the prothrombin times could be very, very different. And that led to a lot of problems, you know, putting people at risk for bleeding or clotting if they were going, you know, to different labs. There was also a big discrepancy between North American literature and European literature, because the thromboplastins that they were using in Europe were very, very different, much more sensitive than the thromboplastins that were being used in North America. And so the European literature and the North American and European literature did not match. So in the 1980s, the World Health Organization got together and decided that they would develop a standardized way of reporting prothrombin times, and that is the INR. So you may hear patients say, oh, I'm going to go get my pro time or my prothrombin time. It's an old phrase. The test is still the prothrombin time. That's the actual test that's being done. And then the INR is a calculation based on that. So I'm going to talk about doing INRs in a laboratory with a venipuncture, and then in a little bit we'll talk about fingerstick INRs and how that differs. So in a laboratory, first you have to have a phlebotomist draw a sample from the patient's vein. That sample is drawn into a 3.2% sodium citrate blue top tube. So one question that comes up sometimes, patients will say, well, I had a CBC or I had other labs drawn, can't they do the INR off of that tube of blood? Unless it was a blue top tube, no, they cannot. It's a very specific type of tube, very specific reagent that has to be processed in a special way. When that tube is drawn, it's important that the tube be drawn all the way full. So to the top of that paper tape, you can see that's my hand holding a blue top tube. I'm right-handed, so I took the picture with my right hand. It's my left hand. You can see in the bottom of the tube there's a little bit of clear liquid. That is the sodium citrate. The blood has to go all the way to the top of the paper tape. That ensures that the ratio of whole blood to citrate is 9:1. The citrate is a blood thinner, and it keeps the blood from clotting while the test is being processed. So if there's not enough blood, if the tube is underfilled, it will give you a falsely long prothrombin time, falsely high INR. So every once in a while you might see a patient sample, or in the lab it would say quantity not sufficient, and that meant that the tube was underfilled. So after the lab tech draws that blood, they invert the tube gently, don't shake it, invert gently several times to mix the blood with the citrate, and then it's put into a centrifuge, and it's centrifuged at high speed for about 5 minutes. And what that does, the heavy components of the blood will go into the bottom part of the tube, and what's in the top of the tube is the plasma or the serum, and that's where the clotting factors are. Then you take that tube of blood that has been centrifuged and you put it in your analyzer, and the analyzer will add a chemical thromboplastin, that's just a chemical that makes the blood clot, and calcium ions, and then it times how long does it take for a blood clot to form. Blood clot formation is sort of like putting the brakes on when you're driving your car. The clot doesn't form instantaneously, it's a process. So I think of the prothrombin time kind of like a skid mark, like how they use a skid mark to determine how fast was the car going at the time of the accident. The longer the skid mark, the faster the car was going. Same thing with that fibrin clot formation. The longer it's taking for the blood to clot, the longer that process is taking. Your analyzer will detect when the clot first started to occur, when the clot formation was complete, and it takes the midpoint of that, and that is the prothrombin time. That's how many seconds did it take for that clot to form. What's the midpoint? That's the prothrombin time. Depending on what kind of analyzer you have, that may be a photo-optical, in other words, a laser looks through and sees the clot, or it could be electromechanical. That, what happens is there are metal shavings and a magnet. The metal shavings shake as the magnet spins around. And as the blood clots, the metal shavings stop moving because the clot made them stop. And that's how an electromechanical device would detect the clot. I've used both types of devices. It's just, one manufacturer likes it one way or another. I think one thing that is kind of nice about the electromechanical method is that it's not subject to interference. Like if the person has really high triglycerides, that top phase of the plasma, say they ate a bunch of French fries and then they came in for their blood draw and their triglycerides are really high, sometimes that phase can be so thick, creamy looking that a photo-optic device can't see through it. And then you would have to send that sample to the lab and have it ultracentrifuge. So it just delays getting that test result. Fascinating, right? And then your analyzer will just take that prothrombin time and calculate what the INR is using this formula. So it's basically your patient's prothrombin time divided by a mean normal control. The mean normal control is like once a year you would take samples from 30 patients or 30 people who are not on blood thinners, and you just average whatever that prothrombin time is, and then you would enter that into your analyzer to use that calculation. The ISI it's an international standardized sensitivity index. That is a number that is provided by the manufacturer of the thromboplastin. So, for example, when we would get a new lot of thromboplastin, say once a year, we would get a whole bunch so that we didn't have to do the calculations over and over again. We would have to do our mean normal controls, and then we would have to program the analyzer based on whatever the package insert said the ISI should be. And I always thought it was interesting that even, say, from one analyzer to another analyzer, depending on what model or make you were using, the ISI might be different. You had to pay attention to all this stuff. So the INR, basically, it's just math. Some important things to know about it, when Dr. Foster was talking about, initial warfarin doses and you're monitoring that INR more frequently, I think it's relevant to at least recognize that the INR was not derived for that use, and it was not derived in patients like that. The INR was derived in patients who had been on stable warfarin for at least 6 weeks. So when you're talking about a new patient, the INR is the only test we have, so we have to use it, but it may be somewhat misleading, especially if you are giving booster doses, loading doses of warfarin. It's also important to know that the INR was developed using a very specific thromboplastin called Innovin. It's very, very, very sensitive. Most labs are using reagents that are not quite that sensitive. Theoretically, the INR calculation takes all of that into consideration, but it is not a perfect system. So I stole this from somebody, issue not resolved. INR is supposed to be international normalized ratio, but it's really issue not resolved. So as you can imagine, running a lab with a person doing the venipuncture, running the laboratory tests, and then seeing the patient in real time was pretty slick. You have to have a pretty large volume of patients in order to make that, work financially. But, when you're talking about patients on warfarin who may have a lifelong need to be on blood thinners, they may be going in for blood draws twice a week in the beginning, weekly, every other week, once a month maybe for the rest of their lives. They may develop scar tissue where the blood is being drawn. They may be traumatized by the blood draw itself. If anybody in here has ever had a bad blood draw, you don't want to go back. And so using finger sticks definitely has utility in monitoring people who are taking warfarin. The nice thing about doing a finger stick INR is that you get your result within about a minute. It's useful for anticoagulation clinics. I do finger sticks pretty much every day at work. Physician offices. It's really handy for visiting nurses. If they're going to a patient's home, they can bring their little portable meter, do a finger stick, call the result to whoever is responsible for that warfarin, rather than doing a venipuncture, taking it to the lab, and having that result being delayed. She says, don't worry, I'll find a good site soon. This is what our Coagucheck meter looks like. There are several different manufacturers of home INR meters. The one that I find correlates best with our lab is this particular brand. You do have to select your patient pretty carefully. The patient has to be reliable. I have some people who, once I got them a home meter, never heard from them again. Or, you want to have a patient who's a good communicator, listens to their messages, is reliable about doing the testing in a timely way. Most of the home INR meter companies will require that the person test at least every 2 weeks, and some of them require weekly testing. So it's more frequent testing. The reason why they did that, they got it FDA approved for home use under those circumstances, because they found that the more frequently a person is monitoring their INR, the higher percentage of time their INR was in range. And so it is a safety issue for home use. We don't know if the person is really calling in what came up on the meter. We have patient whose INR is always 2.7. It's like, really? 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 It is harder to get a finger stick result than you might think. You have to have a pretty big drop of blood. They say about the size of a ladybug. It is important, once the finger has been pierced, the clotting cascade has started, so the clotting process is starting. So if you don't get that drop of blood onto the test strip pretty quickly, the longer you wait, the shorter that prothrombin time and lower that INR is becoming while you're doing the test. So you can't mess around with it. It's also important to note, this is measuring whole blood, whereas with the venipuncture, that was measuring the clotting factors in plasma. So it is a different test. This question comes up from patients probably at least once a month for people who go to a laboratory, and they look at their lab result and it says that it's abnormal, and they freak out because they say, Karen, you told me my INR was good, but this says it's abnormal. Any ideas? Why is it abnormal? Jupiter.
Because it's based on their range and not any specific test.
Right, yeah. So a normal prothrombin time is what you expect in a patient who is not taking a blood thinner. And we're looking for an abnormal result. We want an abnormal result in our warfarin patient. Does that make sense? People freak out. So normal INR is usually right around 1, and that is for a patient who is not taking warfarin or any other blood thinner. They're not malnourished, they don't have end-stage liver disease, and they don't have any underlying clotting disorders that affect the INR test. Dr. Foster did allude to antiphospholipid antibodies in her presentation, and that warfarin is preferred in patients who have that condition. Some of those folks will have a baseline INR that is elevated, and so sometimes their INR target has to be adjusted for that. That would be, we turn to our hematology friends to set those standards or those goals. For most people taking warfarin, the therapeutic goal for their INR is that it would be between 2.0 and 3.0. And if they are in a higher risk category, for example, a patient who has a mechanical mitral valve is at higher risk for blood clot formation. People maybe who've had a breakthrough clot while on therapeutic warfarin, we might increase their target INR to 2.5 to 3.5. INR of 4 is considered critical in our lab at Nebraska Medicine. That's a pretty low INR for critical, so we get a lot of phone calls because it's not unusual for people to pop an INR up above 4. Many labs will choose a higher INR as their critical. It's really whatever your laboratory professionals have determined. I think the reason why Nebraska Medicine chose 4.0 as their critical, first of all, when the World Health Organization developed the INR, it was only standardized for INRs between 1 and 4. Any values that were higher than that, they threw out. So when you have an INR above 4, there's a lot of variability. Even in the same sample, you could run the same sample 3 or 4 times and get 3 or 4 different results. So it becomes slippery up there. And then, as Dr. Foster also alluded, the INR is not relevant in people who are taking DOACs because the DOAC does affect the INR to variable extents. So I like this slide, and I always showed it to my new patients because I think it's just a really nice representation of risk. So on the slide along the bottom, the INR is going from 1, which is normal, up to 5 or higher. When the INR is below 2, the clotting is normal, which means if they have an underlying risk for thromboembolism, that's where they're at risk for having a blood clot. As the INR gets higher, the thromboembolic risk reduces, but then the hemorrhagic risk goes up. So that INR 2 to 3 target is really where those two lines intersect and where the curve is the flattest. And it also, I think, shows, up to 3.5 or even up to 4, the curves are still fairly flat. It's really when the INR gets up above 4 is where the hemorrhagic risk kind of takes off. So how often do we need to repeat INRs? Well, if they're stable and we haven't been changing their doses and they eat the same foods and they do the same things, 4 to 6 weeks is pretty typical. I have one guy in my clinic who insists 12 weeks, 12 weeks. And you know what? I can't argue with him because his INR is always in range. Every time he comes in, it's good. Now, and he and I have an agreement, hey, if it starts to do something funky, we're gonna have you back sooner. I think that's the hardest thing on my end when we have people who are on extended INR follow-up is when you need to dial it back and have them in more frequently, there's a lot of pushback with that. Unstable patients or new patients may be getting an INR tested every day. In the hospital, it's every day on a new patient. When they are first discharged from the hospital, newly started on warfarin, it's probably going to be twice a week. So that is a lot of effort in doing those tests. Dr. Foster already talked about drug interactions and talked about other things that can affect the INR, such as vitamin K intake, poor adherence to the regimen, et cetera. So you've already seen that. Does anybody have questions? Do you have experience with INRs, either with family members or yourself?